With that in mind, I'll get underway. I just want to say that the first time a family arrives at specialised clinic like the paediatrics Tourette clinic at the South Health campus that was at the Alberta Children's Hospital, but is no longer, to be seen by a specialist in Tourette syndrome, they may be confused about what a tic actually is. As the path to healthcare services is sometimes a long one, perhaps between different diagnoses or conflicting medical opinion, the moment a family actually has the first appointment with a specialized Tourette's doctor, it's a great relief. And primarily because they are told what tics are. The confused understanding that may have existed about their child's tics begins to lift, and things clarify as the process moves towards a diagnosis. And this evening, I'm going to continue the clarity with regards to tics and Tourette's specifically. Just a bit of my background. I've spent a lot of my life in teaching. I often met young people in high school, that is, in the classroom whose behaviours and struggles I felt were perplexing. And as a teacher, always wanted to create open environments. Um, I kind of realised with my lack of understanding of what some of their conditions were. I now know were Tourette's, were OCD and other associated conditions. So that lack of understanding, I think, from a teaching point of view, often prevents students from achieving their potential and feeling included and comfortable in the classroom. And that's obviously imperative. So when this opportunity came along to learn more about Tourette syndrome and OCD and work in the Tourette's clinic, it seemed like a really good fit and a natural movement from the classroom to sort of providing psychoeducation in the Tourette's clinic. Okay, so objectives of this webinar are to define and characterize tics, to discuss tics in relation to Tourette syndrome, to describe co-occurring disorders, and to outline the recommended treatment for tic disorders. So that fits in with my opening gambit that essentially this webinar is for parents who've had a recent or a new diagnosis, but of course it's for others too. Um, so, okay, so what are the origins of Tourette syndrome? Tourette syndrome was named after the French physician who initially characterized the condition, Gilles de la Tourette. He was a French neurologist who lived between 1857 and 1904, and the namesake of Tourette syndrome, a neurological condition characterized by tics. His main contribution in medicine were in the fields of hypnotism and hysteria. And in 1885, he published his account of 9 patients with what he called convulsive tic disorders. He concluded Tourette syndrome was a brain-based neurodevelopmental condition and a genetic disorder characterized by tics. Okay, so what are tics? So how is a tic defined? Defining exactly what a tic is vitally important because in doing so, we begin to distinguish it from other body-focused repetitive behaviors. For example, like OCD. And as I'll explain later, they may share common features, but the treatments are different. So a tic is a sudden, rapid, and recurrent motor movement or vocalization. It is also non-rhythmic. So there is a motor tic being an action, and a vocal tic, which is a sound. These motor and vocal tics are seen as normal, but they are out of their usual context, which often creates issues for the person with tics, be it in a work situation or for children, students in the classroom, excuse me. So tics are distinguished by type. As I said, there's the motor tic and the vocal tic. So these are the type here are kind of simple tics. So you might blink because something irritates your eye. You might cough because something is stuck in your throat, or you have a bad cold. And talking about the context, these are usual comprehensible contexts. But if you blink or cough suddenly for no reason, they could be deemed to be out of their usual context. And that's what sometimes garners the attention of people when people are either coughing in a situation where they're coughing repetitively or it's very loud. And as seen, tics are distinguished by type and complexity. And Again, motor tic is a physical movement and a vocal tic is an audible noise. Um, so they're called simple tics because they involve a single contraction of one muscle, okay, or one muscle group. So eye blinking, eye movements, grimacing, nose twitching, mouth movements, head jerks, shoulder shrugs, and abdominal tensing. These are the main tics that we see in the clinic. Often it will start with eye blinking as a motor tic, and it will kind of move on from there if it does progress. They are sudden, they're brief, essentially they are meaningless in the sense that they don't have a purpose. Blinking without needing to, or eye rolling out of context. So, for example, eye rolling can be perceived as a rudeness, and I've seen that in the classroom where a child has an eye rolling tic, and the teacher doesn't understand this and deems that this student is, or deem that the student is being disrespectful, or showing that they're tired or bored, when in reality it has no purpose. Um, so there's always that potential for the misconstruction. In the same way, vocal tics are sudden and meaningless noises which include throat clearing, coughing, sniffing, screeching, barking, grunting, whistling, sucking, and spitting. And again, those first two are the most common. So often simple vocal tics will be throat clearing, and the simple motor tic alongside it will be blinking. So this is not an exhaustive list. Any noise or sound has the potential to be a tic, and they can be very loud. Um, so as implied, suggesting tics are distinguished by complexity. I spoke about simple tics before, and they can be complex. Now, complex tics have the appearance of being purposeful as they're carried out over a longer duration. But by nature, they're exactly the same in the sense that they're just as meaningless as simple tics. So, for example, someone might run their hands through their hair, and that can seem quite purposeful. But when it's a tic, it isn't, and it's obviously difficult to distinguish that. Or certainly shouting out inappropriate or aggressive words. If it's someone's tic, then there's again that opportunity for misconstruing it if we don't understand that it's a tic. So the complexity is a relative one in terms of the physical movement. Gesturing with your hands is more complex than blinking. Uh, Complex motor tics are longer and slower, which give them the appearance of being purposeful, as I've been saying. So um, they're rarely seen in the absence of simple motor tics. So it's very rare for someone with tics to in the initial period to develop complex tics because there is generally an evolution from simple tics to complex tics, and it generally takes a number of years for that to occur. So again, here are some of the complex motor tics. Touching objects yourself, incredibly common one that people have to touch things around them, other people. Again, quite difficult if they have to touch other people. Gestures with hands, holding and twisting limbs, and obscene gestures. Okay, so complex vocal tics, syllables, words, phrases, statements, odd patterns of speech, repetition of another person's spoken words, and obscene, inappropriate, and aggressive words or statements. I have seen all of these tics at the clinic. They are complex because uttering prolonged sound is a relatively more complex than screeching or sniffing. So words might be common ones are what, okay, or bang, and phrases can be, oh no, here we go, I know, and it's often they're quite similar in, or many patients share those tics there. And these phrases might be uttered completely out of the social situational context the person finds they're in. Again, that causes a great deal of difficulty. So it's interesting to note that one of the things I come up across all the time when I'm speaking to parents who've just been diagnosed, their child has just been diagnosed with Tourette syndrome, is that pervasive stereotype of someone with tics is, they blurt out obscenities. Um, and that's it's known as coprolalia. And in reality, it's untrue. Less than 1 in 10 individuals with Tourette's is affected by coprolalia, and in children, it's generally even less. Okay, so more examples of out of complex vocal tics. I love chocolate. I've heard this tic. Others might be shut up, Again, I know that causes a lot of problems in the classroom. What's for dinner tonight? You're fat. And you can imagine that in a public setting, or as I said, in a classroom, for example, such utterances can cause problems um, uh, because there's that sense of, as if they're saying them on purpose. Um, okay, so what are the characteristics of tics? Okay, I'll have a list of them here. And sorry, just check that. So I always found this quite interesting, some of these here. So tics are suppressible, but it can be very difficult. Okay. Now, some individuals demonstrate a high degree of suppressibility. Now, it does change across um, patients. Now, you can imagine doing this in the classroom or social situations, and you probably know this yourselves. Perhaps your children do the same thing. That ability they have to, or that need they have to suppress their tics in the classroom is highly pronounced, meaning that often when they leave the classroom and go home, there is an increased intensity and frequency in their tics. But what it also does when they are suppressing their tics, excuse me, is that the concentration distracts them from the situation they're in. So if the teacher doesn't understand that the child has tics, they won't understand why they're distracted. And you have a child who cannot concentrate in the classroom. Um, and it does have implications for teaching and learning. There is a higher degree, however, of suppressibility in adults, as you probably might expect. So tics are also distractible, playing of sport, music, anything that's active. And I see that quite often. Might have a young person who has fairly frequent tics, quite intense. They may play hockey, they may play tennis, and their tics while they're playing sport will cease or reduce significantly and sometimes even cease. So tics are suggestible. Again, when I'm in the clinic and a consultation and I have an opportunity to speak with the family on their own, and I'll speak to the young person and I'll ask about school and I say, do you tick in the classroom? And quite often that will trigger them. Obviously, I don't mean to do that, but I need to ask them about their tick. And it makes it very difficult for them to resist the urge to tick when it's mentioned. It's a bit like yawning. Yawning is kind of contagious, isn't it? Ticking is the same. So again, wherever we are, but certainly in a classroom where a teacher might ask a child not to tick, not knowing that they have Tourette syndrome or a tick disorder, and that is the trigger. It will cause exactly what it is they're trying to prevent, which is I so desperately want to go into classrooms to speak with teachers, because just that simple piece of information can really make a difference in a child's life and their teacher, so their learning and their attainment. So variability. Viewing a presentation like this one may give you the sense that there's a uniformity of tick characterization, but the opposite is true. Motor and vocal tics are often highly variable, not only among individuals, but also within individuals. So I often say you could have a group of people in a room who have Tourette syndrome or a tic disorder, and whilst they might share some tics or many tics, they'll all have individual tics as well. So it's highly variable. Um, and Yeah, so their own ticks that because of the nature of ticks in terms of the frequency, they can vary over time because there's this concept of waxing and waning, and it's a common characteristic of ticks, and you probably know this or seen this in your children. It means that ticks can increase and decrease over time, and there may be weeks when the ticks lessen, perhaps even considerably, and then other times when the ticks increase. And then new ticks are added. And sometimes parents or even teachers think, oh, the ticks have gone away for a week, 2 weeks. Perhaps they've stopped, perhaps they've gone away. This is a cessation. And quite often that's not the case. It just means we're in that classic waxing and waning period, and they come back, there'll be new ticks, and there may actually be an increased intensity and frequency. Um, So, of course, exacerbation with stress or excitement, stressful situations like school and conflict at home, that they could create problems. Having to do a school presentation can be an exacerbation for tics, yeah, and also so can periods like Christmas or school holidays. Parents will often recount how during those periods there is an increase in tics because of the excitement generated by that period of time, i.e., school's finished and Christmas is coming. So the premonitory urge. So just before or preceding the beginning of a tic, individuals have a buildup of tension, and it's often commonly described as an itchiness or a discomfort in the body. And I did see someone not so long ago, a couple of weeks ago, it was a young man who described it in a very unique fashion. He said for him, it's a void in his body. He feels this void, and his response to the void is he fills it in by doing his tic. I'd never heard that before, and nor had the neurologist at the time. It's quite interesting. But generally, this discomfort and this itching occurs in different areas of the body, maybe in the palms, might be in their shoulders, in their throat, and the tic is seen as relieving the tension that the premonitory urge creates. So it's like a cycle, and the alleviation reinforces the tics. Okay, now that actual urge is, again, not everyone has it, but most do. And again, children are not kind of cognizant or aware of it until perhaps later when they're around about 9 or 10. But there are some that are aware of it at younger ages. So the premonitory urge itself is involuntary, whereas the tic, which can relieve the urge, is voluntary. Okay, so the tic is a response to the urge. So, and this is why tics are sometimes referred to as semi-voluntary movements, because the tic in itself is actually voluntary. Um, Now, as I say, not all people have feel the premonitory urge or aware of them. But the knowledge of that premonitory urge is really important in terms of behavioral therapy and suppressing tics. That's why behavioral therapy, cognitive behavioral therapy, is not often recommended as a treatment for children below the age of 10, because they don't have that awareness. Because behavioral therapy and suppression tics are about, the aim of them is to break the cycle by being aware of it. So, because in one sense, individuals are being forewarned through awareness of the premonitory urge, and it doesn't really increase in children until they get older. Okay. So one thing parents will ask when meeting a specialized clinician for the first time is, quite understandably, what causes tics? It's very difficult because there are three main causes. In a very general sense, there can be a complex interplay between the three. So tics are genetic, they're heritable. Tics are to some extent or to some degree passed on from parent to child. It can be familial. And again, when I'm in with one of the clinicians and they ask that question, is there anybody in your family that has tics? It's quite often they'll kind of rack their memories on, and they'll remember someone, an uncle, might even be themselves, or a father or a grandfather who has tics. So and that's really quite common. So neurobiological, specific neurocircuitry of the brain can be a cause. Okay. Environmental factors, the environment, and we've been speaking about that all along, or context in which tics take place, which provides both internalized and externalized factors that have a bearing on tic expression. So, for example, family conflict at home is a real trigger for tics, and the external phenomenon raises stress levels, which are internalized and exacerbates tics. Activities that are seen as unwanted, like homework, they increase anxiety, stress, and tic severity increases. And as I said before, increased physical activity can actually reduce tics and suppress them. So tick severity is crucial to understanding Tourette's. Peak tick severity occurs between the ages of 10 and 12. Tick severity is assessed using a scale, a clinician-rated scale, which we refer to as the YAL scale. Now, in the Tourette clinic, the family completes the form with the clinician, and you have no doubt all done that if you've had a consultation at the clinic. It is a checklist of motor and vocal tics, followed by an assessment of the number, frequency, intensity, and complexity of tics just over the past week. And to an extent, and it does depend on the individual, tic severity indicates impairment. Now, there are some young people I meet that have incredibly severe tics, and they may score or rate the impairment as quite low. Generally, it goes 10, 20, 30, 40, 50, and they might say 10. But there might be another child with a very similar severity of tics, and they'll rate the impairment as 50. So that does depend on the individual. But that knowledge is important because it has a bearing on the sorts of treatment required. Now, reducing tic severity improves quality of life, and the goal of treatment is to reduce tic severity. But it's important to note that tics may vary over time, but they may also improve over time. Okay, so Tourette syndrome. It can be quite surprising for parents and those with tics to discover what the criteria for being diagnosed with Tourette's actually are. And when I tell parents what they are, you can see that they're palpably and visibly relieved. Critically, motor and vocal tics have to be present for 1 year for an individual to be diagnosed as having Tourette syndrome. And it's generally 2 motor tics and 1 vocal tic for at least 1 year since onset. And then that is what Tourette syndrome is. And if it's just, say, a motor tic for a year, then that will be a persistent or chronic tic disorder. So, Tourette's syndrome is just another tic disorder where the person who has them has both motor and vocal tics for longer than 1 year. So I mean, that 1 year is important in the context of waxing and waning because sometimes the intervals can be prolonged, so the tic may not have reduced. And onset of tics has to be before the age of 18 because tics that start after 18 years of age are not considered symptoms of Tourette's. It's also important to understand whether tics are the result of substance abuse from medication or drugs. And of course, it's important to rule out any other medical condition that may cause tics. Okay, the natural course of Tourette syndrome. Now, clinicians refer to this as the natural history of tics, a timeline of what would happen if the tics were not treated. It has been established based on clinical observations. So we have the main onset of motor tics at age 6. They, as I was implying before, generally begin with simple tics of the face, facial tics. Vocal tics appear after motor tics. The severity peaks in pre-adolescence and declines in late adolescence. There's a high rate of natural remission between the ages of 14 and 17. But monitoring of tic-related impairment is essential for making treatment decisions. So it is really important to understand how tics evolve and the challenges they present. It gives families and those who have Tourette's knowledge, and it is knowledge that will help them manage the tics. And that's at the heart of psychoeducation. Psychoeducation is essentially knowledge, information about tics, because it is that will help the family to cope. It reduces stigma by normalizing the difficulties that parents and families and the patient might be experiencing. So as I said, when we're providing an overview of the different types of tics, it's critical to distinguish tics from other ritualized behaviors. So, for example, OCD may present as a hand-washing compulsion or checking behavior, which are obsessive-compulsive related, and therefore treatment intervention for OCD is different. Other psychiatric associated conditions or comorbidities include ADHD, OCD, anxiety disorders, disruptive behavior disorders, eating disorders, psychotic disorders, and substance use. And you can see there, and you may well know this, that more than half of the young people, pediatric patients who have Tourette syndrome have ADHD, and almost half have OCD. And you can see the various percentages there. Disruptive behavior disorders too, which is quite high at 30%. And of course, that does that that knowledge is, I think, so important for teachers because they often don't have that piece. They don't understand the accompanying conditions and how they kind of fit in with Tourette's. Um, so all of these impact quality of life. And they impact quality of life because comorbidities, the associated conditions, have a far greater impact on tic severity. So in children, the severity of ADHD has greatest impact. And I see that all the time. Children will come in to be treated for their tics, but their main problem is the ADHD. And there are medications like intuitive, yeah, sorry, that that work on both ADHD and tics, which is great. But it is the ADHD that will often cause more problems. And in adults, anxiety and depression have greatest impact. Um, yeah, so in a moment, I will discuss the treatment of tics because the treatment of tics is again about improving quality of life. Predictors how Tourette's might develop. So the strongest predictors of high tic scores and OCD and ADHD diagnoses in adulthood. So corresponding tic, OCD and ADHD severity scores in childhood, okay? And being female and ADHD severity predict future emotional disorders. So it's vitally important to diagnose associated comorbid conditions with Tourette's and receive the appropriate treatment. How common is diagnosed Tourette syndrome in Canada? I'll just read through this. So data from the Canadian Community Health Survey, 2010-2011, population-based survey of Canadians aged 12 plus. The prevalence of diagnosed Tourette's in adolescents was 3.33 per 1,000, differentiating there between males. And you see it's much more prevalent in males. In fact, in the clinic, 75% of the young people we see are male. The other 25% are female. And there's a prevalence of diagnosed Tourette's in adults was 0.66 per thousand, again, higher in males than females. And I did, so what I'm really saying there is, in relative terms, Tourette's is not uncommon. And I did read a 2002 study with regards to tics that suggested that up to 20% of school-aged youth reported to have tics for some period, whether that be for a week or a month or a few months. So tics are actually common. So how are tics assessed? So if I take you back to the clinic, it's useful to know what the clinical assessment is for people with tics. And again, you will have been through this with your children at the clinic. Clinical assessment enables the understanding of a range of neurological, developmental, and emotional symptoms. Remember, tics are highly variable in individuals and among individuals. So the clinical assessment is important to make an individualized diagnosis. So family history, the clinician will generally ask questions about whether anybody in the family, as I said, our mum and dad, their parents, their siblings, had tics or associated conditions. And they may ask about anxiety as well, depression, perfectionist tendencies. We know tics are heritable. Medication use, perhaps the person with Tourette's had been previously prescribed medications which indicate psychological emotional issues. So again, it implies the comorbidities of tics. Developmental history, developmental milestones, at what age did the child sit up or speak single words or walk. They are critical in assessing neurological and emotional development. Past medical history may reveal symptoms of or presence of other, conditions. History of tics. How have the tics developed over time? When was the onset? Has the frequency increased, decreased? And then we kind of see, or maybe the clinician can observe and see how the tics have evolved in a period of time. and place them in the known course of Tourette's, a likely development of tics can be made. Often a neurological exam is carried out using a reflex hammer. The clinician will quickly test reflexes to check muscle tone and abnormal movements, check eye movements, gait, posture. They may well reflect the patient's mental status. Neurological examination is important to consider a differential diagnosis, i.e. a different diagnosis, as the clinician may observe an atypical presentation which is not related to Tourette syndrome. And assessment of tic severity, as I said, tic severity is measured by a clinician-rated scale, which is called the Yale scale. And again, it really is important in deciding treatment. Okay, so imperative to screen for comorbidities. I keep saying that. In people with tics, clinicians assess for OCD, ADHD, and other psychiatric conditions to ensure appropriate treatment is provided for the different conditions too. Disorders commonly occurring with Tourette's. Females more likely to have depression, anxiety, and eating disorders. Males more likely to have ADHD and disruptive behavior disorders. Adults and adolescents more likely to have OCD, mood, anxiety, eating, and substance use disorders. And children generally more likely to have ADHD. ADHD in people with tics is again vitally important to assess the impact on the lives of the ADHD symptoms in people with tics. So individuals with both Tourette syndrome and ADHD are at much greater risk for a variety of poor outcomes, including greater academic and social impairment. And that's something that is really important to think about. Again, something that I speak about when I speak to teachers and principals, as I do every once in a while. Social difficulties, more aggressive and withdrawn. The difficulties are amplified in a child with Tourette syndrome who also has ADHD. OCD in people with tics. What's the impact of the OCD symptoms on the life of people with tics? The most common obsessive compulsive symptoms encountered in Tourette's patients are obsessions concerning a need for symmetry or exactness, repeating rituals, counting compulsions, and ordering and arranging compulsions. Certainly counting compulsions is very common in TS patients who have OCD. And obsessive compulsive symptoms, when present in children with Tourette syndrome, appear more likely to persist into adulthood than the tics themselves. Okay. So treatment of tics. There is no fixed threshold to determine when tics should be treated. People with tics vary in their symptoms, and so does the psychosocial impairment of tic severity and associated conditions. So saying before, some people will feel the impairment, or the impairment will be greater in some people than in others. So I'm saying, therefore, it's also an individual choice. How impaired and disabled physically, socially, and emotionally do they feel about their condition? And of course, that's what the clinician has to ascertain. Sorry, my mouth's very dry this evening. And it's important the decision is made collaboratively between patient and doctor, with the patient knowing the potential risks and benefits. Of course, when we talk about the patients and the children, we're talking about their parents too. So the course of treatments, how tics are assessed is important, but the assessment has to be considered in the general context of the course of the treatment that will ensue after assessment. So understanding where tics come from, their natural course, their characteristics, as I'm essentially explaining this evening, is the initial component of treatment, which is, again, psychoeducation. Treatment is individualized, and the two main treatments are behavioral therapy and pharmacotherapy. So let's just look at psychoeducation for a moment. What is it? It's an education about tics and the related conditions, and its related conditions, right? Which is what this webinar is essentially. And our organization, the Tourette OCD Alberta Network, was in part set up for this reason, because parents, before we were set up in 2020, would come to the pediatric clinic and would be given a handout with this information on. And there'd just be some books, some resources they could just try and find themselves. So we felt that that was not particularly efficient or efficacious. So essentially, our organisation was set up to help them access evidence-based research and to have greater care navigation in Alberta, because it was very difficult. But it's all information that's being generated and provided to parents. And there's a variety of resources on our website to understand what Tourette's is, and a variety of forms, books and podcasts, etc. And this ultimately encourages families who have this information to accept and cope with the challenges of Tourette's. Psychoeducation promotes family well-being. What we're trying to accomplish as an organization is to enable peer support, because peer support, knowing others with lived experience, it normalizes the difficulties that families are experiencing. And we do regularly organise psychologist moderated discussion groups for families throughout Alberta. In fact, we had a session or a set of 5 weekly discussions, which actually finished yesterday. So for once a week over 5 weeks, families discuss and share their experiences in a 1.5-hour conversation. It's supported and facilitated by a psychologist. There is an agenda, and the benefits are multiple. Multifaceted. Just knowing Tourette's is actually relatively common can be a kind of comfort, that you're not alone. And if you haven't done so, you can certainly sign up by going to our website or looking at the next monthly newsletter. There'll be more details of the next peer group discussion. So psychoeducation improves quality of life. And now for an individual who has Tourette's, and especially children, the knowledge they and their families gain through psychoeducation obviously cannot stop at the boundaries of their home. Now, school is a place in which stress is heightened and tics are exacerbated, so it's logical that the school teachers and students should also benefit from psychoeducation where possible. I say logical, I think it's logical. Sometimes schools and students don't, and I understand, again, that's not necessarily being critical or cynical. It's just difficult trying to convey to them and underlining just how important this information is, that it's something that should be widespread and diffuse, but sometimes it's just difficult getting into schools because they have so many things on their agenda. Right? That's what, that they're busy. So evidence shows that when peers and fellow classmates know why an individual has tics and what that means for them in school, levels of empathy and understanding increase. And this, of course, takes a lot of pressure and stress off the individual with Tourette's. Now, our own outreach program that we've been doing for quite a few years now, we certainly haven't done anything like the presentations, in-school presentations that we wanted to, but we are measuring its success, because we are it's at the core of a study that we're doing, and over time we're increasingly doing more. So over time we will it's a quantitative study research, and we will no doubt publish a paper on it, because it's an area where very little is known. And just in anecdotally, in sort of the practice I've been doing and just speaking to parents afterwards, it has a massive impact and nearly always very positive. Yeah, essentially, students and teachers lack knowledge to support students with Tourette. So it's critical that teachers identify what academic impairment looks like in a child with Tourette's. In lower grades, a student with high intellectual ability may be a high achiever, whereas in high school, academic performance may drop off due to a lack of critical skills, critical organizational skills, time management skills, generally executive skills. And that does happen, not common, but like children that were doing very well in elementary school have greater difficulties, certainly as they go into high school. But being aware of this enables the teacher to intervene and manage the academic environment for the individual. And one of the core aims of our network is to offer these customized presentations, as I've said, and our outreach program offers a range of presentations including strategies for the classroom for teachers. And yeah, this year we've had a notable increase, so we hope that continues. So treatment options, the two primary evidence-based treatment options for tic disorders are cognitive behavioral therapy, which, believe it or not, is actually the first line, and pharmacotherapy. So treatment expectations, it may result in a range of reduction in tic severity, and addressing co-occurring symptoms and developing effective strategies for tics is really important. And evidence has shown that treatment response among young people with tic disorders corresponds with a 25 to 35% in tic symptom severity. But it's important to note that it rarely results in tics completely stopping. It's not a cure in that sense, but treatment it can be very effective. So behavioral treatment, something called CBIT, which is the Comprehensive Behavioral Intervention for Tics. Many of our patients at the clinic are referred and recommended to, or we refer them to mainly private psychotherapists because it's not available in the NHS. So they are behavior-based therapists who teach people with Tourette syndrome how to manage their tics with the aim of reducing severity. And as I was saying before, the CBIT promotes awareness of tics and the urge to tic. So the more aware you are of that urge, the better it is in terms of being able to have the treatment, because there's the foregrounding, what known as the competing behavior, when the urge is felt, and it's really important to have that understanding. And many people with Tourette's use CBIT successfully, and again, evidence has shown that 50% experience tic reductions, and also seen evidence, read evidence that the CBIT and CBT generally can have an impact for many years, up to 10 years after. So it's really quite important. But again, it's a management strategy and not a cure. Again, just outlining what I said before, the caveats, the limitations, with regards to minimum age criteria, awareness of when the tic is about to happen is really important. So there is some maturity that's required. Generally, CBIT is only used on children over the age of 9, and it's not as effective with children with severe ADHD or severe intellectual deficits. And one of the problems, and it's one of the problems we face all the time, is the paucity of availability of CBIT therapists. We do recommend 2, and they are incredibly busy people. Because there are not too many that have the relevant qualifications, because locating them can be quite difficult, and that's what I try to do. And I know some of you have indicated that you've actually found qualified therapists and have had treatments been quite effective, and sometimes I haven't heard about them, but usually I have. So again, that is another problem. Of course, it's also quite expensive. It's an out-of-pocket expense, and if you don't have insurance, obviously that's quite difficult. But as I said, it is a first-line therapy, but a modicum of maturity is required. So in a general sense, CBIT is a tic awareness training, self-monitoring, relaxation techniques, and behavioral rewards, whereas habit reversal therapy is about a competing response. So let's say an individual has motor tics, which manifests, say, in their raising their arms. The competing response would be to press their arms, or fold their arms, or press their arms and elbow into their sides. Now, the tic and the competing response are incompatible. They can't happen at the same time, and therefore the tic doesn't occur. Now, I've said that very simply there in a couple of sentences, but that is quite effective when that happens over time. And it doesn't take too many CBIT sessions, usually around about 8, to get to the point where it's really quite, there's great efficacy. But it does not mean that it's possible for everyone to control them just by behavioral therapy. As I said before, there is that 50% 50% that do experience tick reduction. Pharmacotherapy treatments, currently no preventative pharmacological therapies for tick disorder. If ticks do not cause significant functional impairment, sorry, I'm tracing it underneath there. It's so small for me, as it probably is for you. Pharmacological treatments are preferred. So there are alpha agonists, which are relatively new drugs, which is clonidine and guanfacine. Guanfacine is intuitive, and they both have demonstrated beneficial effects on both tics and ADHD symptoms, as I said before. And there's the antipsychotic drugs, which can be, again, quite efficacious, but can have sort of greater side effects. And they're often used to reduce severe tic symptoms. But again, antipsychotics, like all pharmacological therapies, require routine monitoring of the individual. So treatment recommendations, the decision to use medication and the monitoring of its impact require careful assessment of the child's overall development and not only the presence of tic symptoms. Clinicians should prescribe medications for the treatment of people when when the benefits of treatment outweigh the risks, of course, and the child's overall development is really important in terms of their psychological, emotional, as well as physical development. So, summarizing, Tourette syndrome is a common neurological disorder, and I think that's quite a surprise to people whom I speak to, who will listen to me, generally schools and educational institutions, because if it were not so much of a surprise, perhaps it would be easier for me to spread the gospel of what I do in schools. Tic severity will improve for most children in late adolescence. So the prognosis for many children is good. Quality of life is impacted more by the comorbidities than tic severity. Okay, so saying that ADHD often has more of an impact than tics themselves. Behavioral therapies are first line for tics, which cause functional impairment, and there are medications which can help decrease tic severity. And at that juncture there, I will stop sharing. And yeah, sorry, I've just noticed that all this time. Can you take my okay. Sorry, I'm just going to help Kelly out there. I do apologize, Kelly. I've just noticed that. There we go. Okay, so again, I'm not a clinician. I'm not a doctor, but I have a great deal of experience in speaking with parents of children with Tourette's. So if anybody has any questions or has any kind of is anything they want to say about anything that I've mentioned, please do. You can unmute yourself, and I'll attempt to answer your questions.
I just wanted to say thank you. I think that my questions have all been answered. It was a really good overview of what Tourette's is. And I probably could have used it a couple months ago before joining the parent group, because I still, it's still relatively new.
Of course.
And my one question was about the awareness part. So thank you. You've answered that. I had some doctors previously say, oh, if the child is aware of a tic, then it's not possible that it's Tourette's. So, and that was just some general GPs.
Wow.
Yeah.
That's
Yeah.
almost
That was before I met you all. So
Yeah.
that's, I kind of was unsure.
Yeah.
And of course, the child that I'm speaking of isn't he's aware, it seems like, that he's doing it. I don't think, like you said, just because of the age factor. Um, I would agree that he isn't aware of the urge that he's having. He just kind of, or else it's just us mentioning it, that he's just saying, "Oh, yeah, I know," and
Yeah,
maybe he
yeah,
doesn't really know. But
yeah.
no, that was definitely a really good overview. Thank you.
Yeah, you're most welcome. And this what I've outlined this evening, I've changed it slightly and I've upgraded the slides, but it is available, it's been available on the website because I do this every once in a while. But yeah, I'm glad that you were able to benefit from this because it's just
I realized that after the fact. Yeah.
yeah, okay. Well, that's great. At least you know that's
I'm
wonderful.
slow. I'm slow with technology, so this was
Ah,
good to be spoon-fed.
sure. And if you want to refer to it again, I will. I'm going to upgrade. I'll just upgrade the webinar that I record. So we'll be back on the website. And I think it's. So I'm changing the website at the moment. Over the next month, it's going to change quite a lot, and I'll make this more prominent. Um, so if you want to review it, you certainly can. Okay. Thank you, Val. Anybody else have any other questions at all?
Hi, Julian. Sorry. You talked about how the ticks can wax and wane.
Yes.
And there could be periods where you don't really see many ticks.
Mm-hmm.
And when you're talking about that, you're kind of talking about maybe for a couple weeks.
Yeah.
Is it possible that you could not see ticks for even a month at a time?
Yes, it is
Okay.
possible. Yeah, no, sometimes even a couple of months. Yeah, I've known of situations where that's happened, and parents and teachers are kind of celebrating, not knowing that waxing and waning, that coming and going is a central characteristic of ticks, thinking that they've gone, that they've ceased, but then they come back. Yeah, so it can be longer than a week, even, in a few weeks, a month, and sometimes can be a couple of months, and sometimes even longer than that. Yeah, absolutely.
Okay, thank you. Yeah, my daughter was diagnosed, what it sounds like fairly young, like at 4 years old.
Mm.
And then there's been periods where I've wondered, like her ticks have disappeared for a month, sometimes even probably closer to 2 months. And I've
Yeah.
questioned whether or not the diagnosis was accurate, but it sounds like that's
No,
common.
no, it is common. Of course, once you know that that is a defining characteristic of ticks, then that is a game changer, really, in terms of the diagnosis. Because it's understandable you'd think that perhaps the diagnosis is incorrect if you didn't know that. But yeah, and even sometimes parents may not even notice their child has a tick for a long time while they're younger, and perhaps it's because they may have noticed it sort of subconsciously, and then it goes away for quite some period of time, then comes back. So it can also have an effect on how parents perceive the disorder in their child, which can be then difficult when they go to the clinic and um, and they have to relay the history to a clinician. But no, that's something that we hear often in the um, in the clinic.
Okay, thank you so much for clarifying.
Oh, you're
And I
welcome.
also want to say thank you for this session. It was really helpful and informative. I
Oh, you're
appreciate it.
most welcome. Thank you for attending.
I have a question. How young can a kid be to be diagnosed with Tourette's?
Um, they can be quite young because if they have, and it does happen. I mean, sometimes. Do you mean Tourette specifically or a tic disorder?
Tic disorder, sorry.
Tic disorder. Um, yeah, sometimes as young as 3.
Really?
Or yeah, I think last week I saw a 4-year-old child come along. Um, they had a provisional tic disorder, so a tic disorder um, that hadn't lasted 1 year yet. So it wasn't a chronic tic disorder, but usually in that first year, if it hasn't gone as far as a year, this child had one. I think it was an eye blinking tick that had it for less than a year, and they were 4 years of age. I've seen a 3-year-old been diagnosed with provisional tic disorder as well.
Is it more likely that they had OCD first and or ADHD first and then
Not
get the
generally,
tics?
no.
No, they usually get the tics first.
Yeah, I've got this great graphic. Maybe I should put it in here because that's, it's a very good question. Generally, OCD symptoms come along around about kind of 10, 11 years of age. So you may see the ADHD first, certainly symptoms, and then tics at a similar time. But OCD generally comes along a bit later. So it can be difficult to kind of unravel them and see which is which, especially in those early years. And if a child has all three of those, certainly in those first, if they say perhaps get a tic or start ticking around about the age of 6, they may have had ADHD just before then. Sometimes it can come after. Then once they come to terms with that, it's 50% of them will also be grappling with OCD. So it's really complex. When they speak about Tourette's being complex, that really is the kernel of it. It's complex because of the comorbidities as well.